Hello, this is Lori Saito. Today we're going to talk about the advanced nursing process. Some of the basic objectives of today's lecture are to review the patient assessment for identifying nursing diagnoses, review components of the nursing process, and discussion of prioritization of nursing diagnoses. So what is the definition of nursing? Nursing is the diagnosis and treatment of human responses to actual or potential health problems. Nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations. So what are human responses? These are reactions to an event or stressor such as disease or injury. For example, in a myocardial infarction, you have several responses. You have the physical response of pain. You have the psychological response of the fear of dying. There could be a sociocultural response, which could be about concerns about returning to work, and you can have a spiritual response where the individual may be bargaining with God. Reactions can be one, a combination, or all of these responses. Human responses also occur at different levels, the cellular, systemic, or whole person level. At the cellular level, in our myocardial infarction example, we have the ability of the myocardial cell to contract, or not contract if it's been damaged. We have the systemic response of the ability of the cardiovascular system to circulate oxygenated blood. And the whole person, you have the ability of the person to cope with lifestyle changes related to coronary artery disease. So what is the nursing process? If you remember from first year, the nursing process consists of several components: assessment, diagnosis, outcome identification, planning, implementation, and evaluation. As this is what makes nursing nursing, let's look at the various components. In the nursing process, the component of assessment, we have different types of databases. The nurse here is collecting and analyzing data. So, the different types that the nurse can be looking at are complete data. This is gathered from a comprehensive assessment at the time of the first encounter to assess all aspects of health status. You may not have time for a comprehensive, so you may have to be doing an episodic or problem-oriented where the nurse is only addressing one issue. A follow-up assessment is where the nurse is gathering data about ongoing problems that the patient may have. This could be like the nurse returning or seeing a returning patient to the clinic. Or you could have emergency databases where data is collected specific to that emergent problem. So there are different things to consider that give you information to make a complete and thorough assessment. One is your conceptual framework. This is the psychological, sociocultural, developmental, spiritual, learning, along with the physiological components for an individual. That's not the whole person, though. If you take a look, you have the body systems model, which on top of the conceptual will add the body systems, such as cardiac, genitourinary, neurosensory. That is added, and you gather information from there. You then gather information from Gordon's functional health patterns. These are going to be the role relationships, value belief, nutrition elimination. That also will give you information on the patient. And finally, you have Maslow's hierarchy of human needs. So this takes a look at the physiological, the physical safety needs, self-actualization, love and belonging, and things like that. And when you put them all together, then we have the holistic model, which is what nursing operates off of. We address all of these issues. So once all the data is collected from these various areas, and we have a holistic view of this patient, of their health issues and responses, and we can start determining what type of health problems this patient has. So that is done through the nursing process of the nursing diagnosis. And from this data, a clinical judgment or nursing diagnosis about a human response to an actual or potential health problem is determined. The reason that a nursing diagnosis is used is that it provides a way to interpret data. This is done by identifying clusters of cues or data that are similar and making inferences from those data clusters. It also helps us to validate inferences to problems which are displayed by the patient. It will help us to be able to compare clusters of cues with definitions and defining characteristics which identify specific problems. And it allows us to document the validity of the nursing diagnosis that was chosen. So to identify a nursing diagnosis from clusters of data, once you've gotten all of your data, the nurse applies analysis or the use of reasoning to determine which nursing diagnosis the patients have. Now there's two types of reasoning that the nurse can use. You have inductive reasoning, in which the nurse begins with specific details and facts and then uses these facts to arrive at a conclusion. Or you can use deductive reasoning, where the nurse begins with a major premise or fact that generates specific details and predictions. In this instance, reasoning is from the universal to the particular. So how is data clustered? To begin clustering, first look at your assessment tool for significant clusters. For example, under respiratory, you have crackles in the posterior lower lung fields bilaterally, productive cough, patient is producing thick green mucus, a respiratory rate of 24, intercostal retractions, and arterial blood gas or ABG values of a pH of 7.32, carbon dioxide of 60, bicarb of 28, and oxygen of 75. The patient is on a continuous oxygen at 3 liters per nasal cannula, and his SaO2 is 90%. So what problem is indicated by this data cluster? It indicates an oxygenation as a problem for this patient. So next, look for data or cues that are repeated in more than one system or health pattern. For example, when referring to your holistic accumulation of data, if you go back and look at slide 11, you glean information from the different categories. In the physiological, under self-perception and self-concept, the patient states, "I'm too tired to worry about my periods." Under psychological, cognitive, perceptual, you have the patient describing a feeling of weak and tired. Musculoskeletal shows that hand grips are weak bilaterally and they're unable to stand unassisted. And activity, exercise, they're unable to participate in self-care due to feeling tired and weak. When you put this all together, these data clusters indicates fatigue and weakness, which is secondary to poor oxygenation as a problem. Then you want to compare data sources across categories of your organizing framework and cluster or group together data that seems related. For example, under GI, the patient has poor fluid and food intake prior to admission. His skin has poor turgor. He has elevated sodium levels with his fluid and electrolytes. Under GU, he has decreased urine output. And his psychological, he has difficulty following commands. This grouping of data indicates dehydration secondary to inability to access food and fluid due to feeling tired and weak due to poor oxygenation as a problem. So why is data clustered? If you cluster data, it's going to help you separate from one problem from another. Some clusters may suggest more than one problem, and some clusters may be overlapping and could be combined. For example, if you were looking at respiratory, as in this patient, he may have a white blood count of 12,000. He's got that thick green sputum. So even though white blood count would fall under immune, it could also fall under respiratory because it's supporting that green sputum as an infection. So the cluster data will be the basis for formulating a problem list and ultimately the nursing diagnoses. One of the things you have to be careful about when you are in clinical is that your nursing diagnoses and your priority nursing diagnoses are not determined until you have done your analysis, and we will cover that in the orientation. You may be seeing something that you're leaning towards that look like it's the most likely to be the top, but until you actually do your analysis, you're not going to have that substantiated as your top ones. Once you have all of your clusters together and you've identified those various health problems and therefore your nursing diagnoses, for your patient, the nursing diagnoses need to be prioritized. So this will help to determine if the problem needs to be addressed immediately, sometime during the hospitalization, or following discharge. So Maslow's hierarchy is one framework for assigning priority. So if you remember Maslow's framework, we start down here at the bottom of physiological because those are the most life-threatening. Oxygen, elimination, and then you move to physical safety, psychological safety. So when you're looking at your nursing diagnoses, all of your nursing diagnoses that fall under the physiological should be ranked higher than safety and security, which should be higher than belonging and love, etc. So as you recall, there are 3 levels of priority problems when you're prioritizing by acuity. So are those problems emergent, which is life-threatening and immediate, such as they're not breathing and they're bleeding? Are they second-level priority problems, which is next in urgency? This is where the nurse needs to intervene promptly to prevent further deterioration. For example, anxiety, fear, environmental hazards, physical activity deficits, violence towards others or self, or a knowledge deficit. Or is it a third-level priority problem? These are important to the patient's health, but they can be addressed after more urgent problems have been addressed. So, once we have all of them identified, then we need to put a diagnostic label or nursing diagnosis on them. So, what is a diagnostic label? They're nursing diagnoses that come from a standard list of diagnostic labels that have been approved by the North American Nursing Diagnosis Association, or NANDA. These are the officially recognized nursing diagnoses and therefore the only accepted nursing diagnoses to be used in nursing. So NANDA has standardized the nursing diagnosis to consist of 3 parts. You have the problem, which is your diagnosis label, and this is where the label is defined. You have your related factors, which are causatory or contributing etiological factors, and you have your defining characteristics, also known as signs and symptoms. So, you have your information, you're taking a look. So then what the nurse does is she looks at the NANDA list of nursing diagnoses and select those diagnoses that most closely match the identified or potential problems. So the nurse here is thinking critically and analytically in this process because some of these things can cross over. It could be, fluid retention, or is it CHF? I mean, she has to decide which one it's going to be. Next, what you do is you determine the correlation between your organized clusters of data and the related tos and the signs and symptoms listed in the defining characteristics. So each actual nursing diagnosis will have supporting patient data. You are trying to determine which diagnosis best matches your data and your cues. When it is written as a formal statement, such as ineffective airway clearance, this is called a nursing diagnosis. Once you've decided on the appropriate nursing diagnosis to identify the problem, a nursing diagnosis is written. There are different types of nursing diagnoses, but all diagnoses are written in the same way. It consists of 3 parts, as we talked about before. It's also called a lot of times PES for short, which identifies problem. Now, these are the NANDA recognized nursing diagnoses as far as the beginning of it. An example of this is impaired skin integrity. Then you have your etiology, which is frequently stated as the related to. So here we have impaired skin integrity related to physical immobilization, low oxygen saturation, and urinary continence. And then you have your signs and symptoms, as evidenced by disruption of the skin surface over the elbows and coccyx. And that is how your nursing diagnosis is written. So nursing diagnoses not only cover actual problems, but problems that the patient is at risk for developing. So these are problems which the patient could develop if interventions are not implemented to prevent their development. So these diagnoses are labeled risk for nursing diagnoses. Any potential problem can be converted into a risk for NANDA diagnostic label. For example, risk for impaired skin integrity. Okay. Here, the etiology, also called the related to, becomes the existing risk factors that contribute to the development of the potential problem. Multiple etiologies can exist in this situation. The major difference between an actual nursing diagnosis and a risk for nursing diagnosis is that in risk for nursing diagnosis, there are no signs or symptoms. No as evidenced by. They do not exist. If signs and symptoms are present, the diagnosis is no longer a risk for, but rather an actual nursing diagnosis. The following are examples of risks fors. Risk for impaired skin integrity related to physical immobilization secondary to total body cast. See, there's no signs and symptoms, no evidence as evidenced by. Risk for inadequate fluid volume related to diarrhea, age 3 years, low oral intake, elevated temperature. Risk for injury related to disorientation and decreased vision after cataract surgery. None of these above examples have signs and symptoms, thus it supports the risk for diagnosis. Now, cautions that you need to keep in mind regarding nursing diagnoses. Do not state 2 problems at the same time. For example, anxiety and fear related to. Only state 1 problem at a time. Do not use medical diagnoses as the related to factor. For example, anxiety related to social anxiety disorder or anxiety related to myocardial infarction. Do not do that. Do not relate one nursing diagnosis to another. For example, anxiety related to fear. And do not write nursing diagnoses that are legally incriminating or based on value judgments, such as anxiety related to patient's whining personality. Other categories of nursing diagnoses that are out there that are not used quite as often are health promotion nursing diagnoses. The patient has a desire to enhance specific health behaviors. Wellness nursing diagnoses, where you have human responses to level of wellness and readiness for enhancement. Syndrome nursing diagnoses, where you have a group of signs and symptoms that usually occur together. And then there are patient teaching diagnoses, for example, knowledge deficit. Once you have your nursing diagnosis identified, then the next step that you're going to do is outcome identification. In this section, the nurse identifies what are the expected outcomes of the care plan related to this nursing diagnosis. How will the patient benefit from nursing care? What will the patient be able to do and in what time frame? Outcomes are patient-centered, individualized, and SMART, meaning they are specific, measurable, attainable, realistic, and timed. So the outcome development should include information and input from the patient. NANDA has also developed, just like they developed the nursing diagnosis, they have developed some standardized outcomes, or called NOC for short, to help a nurse write an outcome if they need a place to start. The nurse can, however, write an outcome yourself as long as it meets the criteria for an outcome. But if you're not sure where to start with a particular problem that this patient has, these standardized outcomes are sometimes a good place to start. So let me remind you that outcomes are developed for each of the patient's nursing diagnostic statement identified, and they must relate to the nursing diagnosis they are connected with. For example, if you have an outcome that the patient will eat 50% of their meal by the end of your shift, or excuse me, if you have a nursing diagnosis of inadequate nutrition, less than body requirements, your outcome should be the patient will eat 50% by the end of their shift. The outcome should not be the patient will be able to walk 50 feet without shortness of breath. So your outcome has to relate to your nursing diagnoses. Outcomes need to be realistic for patients to achieve, and this is the most important component. When developing the outcomes, you need to consider the patient's physical health state and overall progress. If the patient has just had a hip surgery, they may not be able to walk 200 feet by the time they leave. You need to know what their expected length of stay is. That's going to determine what your outcome is going to be, or if you're going to have to continue this plan of care on elsewhere. You don't want to be able to have the patient managing their diabetes if they're only in the hospital for 3 days. That's definitely a much longer goal. You want to take into account the growth and development level of the patient. Are they able to do what you want? And what resources are available to the patient to be able to continue in health promotion once they leave the hospital? Outcomes must be measurable and they must relate to the patient's clinical manifestations. I've emphasized that a few times. So do you think that might be a little problem sometimes in nursing care plans? Yes. So don't forget it, okay? So how are expected outcomes written? You have to have a subject, a verb, a condition, performance criteria, target time, and outcome criteria. And we are going to look at each one of these components. We're going to look at them closer here. So let's look at the component of an expected outcome. You have to have a subject. This is the person who will achieve the outcome. For example, the patient will. The wife will. You need a verb. This is a measurable action. You be aware that it's measurable and don't use non-measurable verbs. So a measurable action is identify, describe, discuss, relate, state, list, verbalize, demonstrate, has an absence of performing, maintain, walk, sit, stand. You can measure those. Did he sit or not? Okay. Non-measurable verbs, and therefore ones you want to stay away from, are examples that are hard to measure. Those are words like know, understand, appreciate, think, accept, feel. So if you're unsure if it's measurable or not, ask yourself, how would you measure that action when it was done? Condition. This is an optional component. It does not always have to be included in your nursing outcome diagnosis outcome. It's the aid or conditions which facilitate the performance. For example, with the use of a cane, with the assistance of physical therapy, with the assistance of family, with the use of medication and diet therapy. Sorry about that. Performance criteria. This refers to the standards indicating the level of expected performance, such as how long, how far, how much. For example, the length of the haul, a decrease in pain level to 4 or less, eat 75% of the meal, a 10-point decrease in diastolic pressure. Target time is going to refer to when the outcome should be accomplished, within 48 hours, by third post-op day, in 24 hours, or by the end of the shift on 10/3 at 3 o'clock. And finally, outcome criteria. These are corresponding indicators describing what it looks like when the problem is corrected. For example, as evidenced by free from signs of skin irritation, absence of skin breaks or tears. As evidenced by respiratory rate less than 18, no complaints of pain, able to sit in a chair more than 5 minutes, or able to sit in a chair without standby assist. Those are all examples of outcome criteria. Outcomes must be realistic for the patient to achieve. When determining if it's realistic for your patient to achieve the outcome goal, take into consideration the following issues. What is the physical health state of the patient and their overall prognosis? What is their expected length of stay? What is their growth and development level? And what resources do they have to enable them to be able to do the outcome? Once you have your outcome, then you have to have your steps on how you're going to achieve the outcome, and these are called interventions in the nursing process. So nursing interventions are actions identified by the nurse to resolve, prevent, or manage a problem or nursing diagnosis and lead to the identified outcomes. Again, like the diagnosis, NANDA has standardized interventions, called NIC, to help the nurse create her care plan for the patient. So again, if you're not sure where to start and what type of interventions you can use, you can start with these standardized interventions that then need to be individualized for the patient, and it'll give you a reference point to start from. Interventions can fall into one of 4 categories. They either monitor health status, you're carrying out therapeutic measures, you're preventing complications and minimizing risks, or you're teaching skills and information to be able to promote optimal self-care. So, where do we get our nursing interventions? You can get your nursing interventions from just about anywhere. You'll find them in nursing literature, standards of care books, your textbooks, nursing handbooks. You can even pull it from your own Ready reference. Remember, Ready reference is everything you've learned so far in nursing. So if you find a nursing intervention under a different diagnosis that applies to the outcome for your identified nursing diagnosis, it is okay to go ahead and pull that intervention to use under your nursing diagnosis to help the patient optimize their health. You are not limited to just what is in that one section. So, intervention statements. Interventions should be individualized to meet patients' unique needs, and they need to be measurable and specific. Components of the nursing intervention to help accomplish this are how, when, where, how long or often, with what, and for what. In grading nursing care plans, one of the biggest things that it gets left out is 2 things. 1, when are you going to do it, and how often are you doing it? So those are the components that need to be addressed and put into your intervention. For example, irrigate the right leg wound with 200 mils of normal saline every 6 hours. Intervention should be based on sound rationales from biologic and behavioral sciences, or what we call evidence-based practice. For example, an intervention You're going to monitor the respiratory rate for a decrease of less than 8 and for shallow breathing every 2 hours for 12 hours or until stable. And the rationale why you're doing this is that most anesthetic gases depress the respiratory rate and depth, thus interfering with oxygenation. Another example is that you're going to collaborate with the patient to implement a plan for smoking cessation by the end of the shift. And the rationale for this is that active participation in decision-making about the therapeutic regimen may increase compliance. Then you need to put the plan into action. This is a very basic step, but it needs to be reminded. With each patient encounter, when you put it into action, it's going to be with each patient encounter, you're going to assess the person's current status and set daily or hourly priorities. Are the priorities still the same at 2 o'clock as they were for my patient at 7? Has the patient's status changed, requiring a change in my nursing plan of care? So you need to keep assessing everything. You're going to perform planned interventions and reassess to evaluate the patient's response. Was the response positive? Are there any modifications to the plan necessary? And you're going to record and report the implementations. Are there any findings that should be reported to the healthcare team immediately? What findings should be charted? And don't forget to chart this because, as you know in nursing, if it's not documented, it's not done. And finally, you have the evaluation step in the nursing process. And the evaluation step has 2 primary purposes. One is the evaluation of the patient's overall progress towards meeting the expected outcomes, which are patient-focused. That's a patient-focused evaluation. And 2, it's a continuing, ongoing assessment with the application of the nursing process. And so that one is nursing-focused. So when you're doing your evaluation, you need to determine whether or not the patient has partially met, or not met their expected outcome. Compare the patient's current status to the identified outcome. Is the patient progressing towards meeting the outcome? And if not, why? You want to determine if further referrals for healthcare promotion or support are needed to maintain the achievement of the expected outcome. Should the patient be followed by a home health nurse following discharge? And decide whether to continue, modify, or resolve each nursing diagnosis. So, what are standardized care plans? Standardized care plans are pre-formulated plans of care that identify the nursing diagnoses, outcomes, and related interventions common to specific health problems or patient populations. They are excellent bases for the initial plan. However, you have to individualize the plan for the patient, and that is done by the RN. This is your ACLI, your book of ACLI. Also in the hospital, you'll have standardized care plans for the total hip population, the pneumonia population, where things have been identified for that disease process as things that can be done. And then that plan is individualized to the patient and what their needs are. But they're a great way to start looking to decide what you want to do for your patient. So steps for individualizing. First, of course, you have to select your appropriate standardized care plan. Add all the other related nursing diagnoses that have been identified by the health problems that you picked up on when you did your complete initial assessment. You want to determine expected outcomes and modify those so they are realistic for your patient. And you want to choose the nursing interventions that will assist in the achievement of the expected outcome. Add specific detail to the interventions that indicate for what, how much, how often. And that's individualizing your care plan. So why is the nursing process important? And not just because we make you do it in nursing school. The nursing process encourages you to critically think, problem solve, and make decisions about patient care. It prevents you from losing sight of the importance of the human factor of your patient and from making sure that your care is holistic in nature. because that is what nursing is. Medicine is identifying a problem and solving it. We as nurses take care of the whole patient. So the nursing process is going to focus your attention on each patient's unique needs, which may or may not be met by a standardized plan of care. So, in remembering that this is a holistic model, keep in mind the words of Florence Nightingale in closure as we end this lecture, that one must nurse the whole person rather than a disease. Thank you.